So, hi students, like we are posting PYQs in my Instagram page since 2 to 3 months. We have finished all the 100 PYQs, and as we have discussed and we have been saying that, like, I'll be summarizing all the PYQs in a rapid session in a ultra rapid mode because you already are having the PDFs. You have read the PDF, so what are the keywords you should highlight and what are the keywords you should know? That is my purpose of rapid review of all the 100 PY. So let me take the first question. Which of the following is a mortality indicator? Answer is life expectancy is a positive mortality indicator. Notification rate, morbidity indicator. Sullivan's index, very old disability indicator. Bed turnover ratio is healthcare utilization indicator. Denominator for calculating proportional mortality rate. What is the denominator? Total deaths. Numerator is deaths due to a disease. Like if I want to calculate the contribution of TB, then I'll say deaths due to TB divided by total deaths into 100. So this is a proportion. Denominator is total deaths due to all the causes, indicating contribution or burden of disease. Mortality indicator indicating burden of disease is proportional mortality rate. Case fatality rate will indicate virulence of a disease. Which of the following is used to assess how good is the treatment? Standards of treatment, especially in chronic diseases or cancer. Your answer will be survival rate. 5-year survival rate will indicate two things. One is prognosis, second is standards of treatment. If these two words come in the exam, your answer is 5-year survival rate. Prognosis and standards of treatment. Which of the following is used to compare mortality rates between coal workers and general population? Occupation versus general population. Answer is standardized mortality ratio. It is always used to compare which occupation is having more risk compared to general population. Formalize observed deaths by expected deaths. Observed deaths will be given. Expected deaths what you calculate by using indirect standardization. I'm not going in detail. It's not that important. Indirect standardization means where you take the rates of study population, apply it on a standard population. So then you will check and you will get expected deaths. Using expected deaths, observed deaths are already given. If it is more than 1, if the ratio O by E is more than 1, occupation is having more risk of death. If the standardized mortality ratio is more than 1, how to calculate? Observed deaths by expected deaths. For calculating expected deaths, what you are supposed to do? Indirect standardization. True about prevalence of disease means how many are having disease at one point of time. You are taking the burden. You are not doing follow-up. It is at one point of time. It's a measure of risk, no? It is burden. Risk is given by incidence where you do follow-up. Prevalence will indicate burden. Studying etiology, no, you are not doing any follow-up. Temporal association is not proved, so you are not studying any etiology. You are not doing exposure to outcome. That sequence is not studied. Decreases with increase in duration of disease, no, it increases with increase in duration of disease. P is equal to I into D. You know the equation. Prevalence depends on two factors. Incidence is more, prevalence will increase. Duration is more, prevalence will increase. Chronic diseases, more prevalence. Decreases with increase in case fatality, correct. Increase in case fatality, acute illness like rabies, duration is lesser. If the duration comes down, there is short duration, prevalence will also decrease. Very, very important question. A new drug is reducing the mortality of stage 3 cancer patients, prolonging the survival but not curing the disease. You are just prolonging the survival of a non-communicable disease. The duration is increased, not curing the patients. The duration is increased. Prevalence will increase, but incidence will not change. You are not preventing the cancer, so it has nothing to do with incidence. If you are preventing, then incidence will decrease. Here you are not touching, or you are not touching any preventive part, you are just prolonging the survival. Duration is increased, prevalence will increase, incidence will not change. Human development index does not include. So answer is adult literacy rate is not a part of HDI. HDI has three dimension: knowledge, income, longevity. What is a mnemonic? Kill. Knowledge, income, and longevity. Within knowledge, we are taking two indicators: average years of schooling and expected years of schooling, not literacy rate. Income per capita, GNI, gross national income. Longevity, it is life expectancy at birth. We take the average. Later geometric mean we take, it ranges from 0 to 1. It ranges from 0 to 1. Hypertension can lead to both mortality and morbidity in a group of population. Correct? Which of the following indicator indicates burden of disease including both together? Means your answer is dailies. Dailies will consider both mortality and morbidity pattern of a disease. What is the formula? YLL plus YLD. YLL means years of life lost due to premature death. YLD is years lived with disability. Both the component are studied. Dailies will include both mortality and morbidity. What is the formula? YLL plus YLD. This question is very important. A new intervention for cervical cancer is prolonging the life by 10 years. This is quantity, what you are prolonging, quantity, with utility value of 0.6. Utility value will indicate quality of life. Quality of life. What we have discussed in your classes, we have to include quantity and quality both. Then the overall picture of a intervention, how good it is. Effectiveness you are checking. This is the question. See the question properly. Effectiveness of intervention, considering both quantity and quality of life. If this is the question, 100% answer is qualis. Will include both quantity, how much it is prolonged, and how it is prolonged, how they are living, what is the quality of life. Quality of life is given by what values? Utility value. Qualis are used to tell how good is the intervention. Not true for pathogenesis phase. Natural history has two phases: pre-pathogenesis and pathogenesis. The question is on pathogenesis phase. Within host, what are the changes? Tertiary prevention is possible. Yes, we can do secondary, we can do tertiary, both. Entry of organism has happened, that is also correct. Includes subclinical cases, that is also correct. Screening has no role. No, screening can change the sequence of disease. So pre-pathogenesis, where there is epidemiological triad, there is interaction, agent, host, environment. Here we do primary level of prevention. Risk factor is present. If I don't take vaccine, for example, the agent will penetrate. When the agent penetrates me, there is change. That is called as pathogenesis. Either you can do secondary level or you can do tertiary level if it is after complication. Which of the following is not a direct method of direct transmission? So thoda sa mushkil question tha ye. Listen. So droplet nuclei, we say it is an indirect mode of transmission. There are two types of transmission. Direct means either in coming in contact with a secretion. Droplet infection will go in direct mode, that is transmission in between 1 to 1, 30 to 60 centimeter distance. Soil, like you come in contact and you get tetanus. Inoculation, like dog bite or needles. Vertical transmission. All these are direct modes. Indirect modes, you need someone else to carry the agent, like food and water, vehicle. Droplet nuclei means airborne. See the question. Droplet nuclei was indirect mode of transmission, or even dust. Vector, fomites, hands. All this you need someone else to carry the agent, either food, water, air, vector, fomite, hands. Indirectly, what I made the question difficult, because droplet infection is direct, droplet nuclei is indirect. Airborne transmission. Man is dead and host. For this is the question. Man is dead end host for answer is tetanus and Japanese encephalitis, where there is no further transmission, like Japanese encephalitis, tetanus, bubonic plague, hydatid disease, trichinosis and rabies. Why there is no further transmission? Because there is no further route of exit, there is no portal of exit. These infections are called as dead end infections. Infection transmitted to man from vertebrate animals, dog to man, rats to man, it is anthropozoonosis, where man will suffer with. So example, rabies, plague, anthrax. If it is from man to animal, like human TB in cattle, that is zooanthroposis, also called as reverse zoonosis. Either direction, that is amphizoonosis. Repeat, animal to man is anthropozoonosis, like rabies. Man to animal, ulta, reverse, that is zooanthroposis. Either means amphibian, amphizoonosis, either direction. But for you, anthropozoonosis is very, very important. Exotic disease means not present in India. Like for example, yellow fever, which is absent in our country. So the next question is on secondary attack rate. See this question. Two parents and five unvaccinated children. One case of measles happened. So primary case. Later, three secondary cases developed within one incubation period. Calculate secondary attack rate means the denominator is very important, that is susceptibles in the family. Parents are not susceptible, so leave it. So we are excluding them. Just within children we have to count. Within children, five unvaccinated children are susceptibles. But within that, one primary case happened. So 5 minus 1. Five unvaccinated children, but within that primary case happened, so primary case will be excluded. So the denominator is 4, numerator is 3. 3 by 4. Very easy question, because I am not giving three dimensional, just I am giving five unvaccinated children directly. These are susceptibles. Within that primary case happened. So 4 in the denominator. Numerator, how many secondary cases? 3. So secondary attack rate is 75%. 75%. Which of the following is not an use of incubation period? Isolation is decided based on period of communicability, not related to incubation period. To trace the contacts, yes, very important. To trace the source also. Period of quarantine, observing them for maximum incubation period. Period of surveillance to the incubation period, twice the incubation period. From the day of last case, we have to follow twice the incubation period. Quarantine is for maximum incubation period. Tracing the contact going back and how many have been exposed in related to that incubation period, that is also counted. So isolation is based on period of communicability, not on incubation period. Point source means single source. One way will happen, sharp rise, sharp fall. So which is false. Epidemic curve rises, sharp rise, sharp fall, correct. Clustering happens, correct. Person to person transmission, no. Where there is person to person transmission, it is seen in propagated epidemic, not single source epidemic. Cases develop within one incubation period, correct. Like food poisoning, you will develop within 4 to 6 hours. This is single exposure, also called as point source. When they show this image, person to person transmission, this is propagation, propagated epidemic, like polio, COVID, etc. True about herd immunity except. Very important question. It is referring to a group protection which is afforded by some immune individuals. Yes, I am having this much of immunity in the population. These will protect the other individuals. The whole group is under protection, herd immunity. It is likely to be more for infections that do not have subclinical phase. That have subclinical phase, they will develop antibodies better in the body without manifesting any symptoms. So herd immunity will be more if the disease is having a subclinical phase or an asymptomatic phase. It is affected by presence and distribution of other host, that is also correct. In case of tetanus, it will not protect. Yes, it will not be useful for tetanus. Highlight this point. There is no further man-to-man transmission. It is not useful for tetanus. Very important question. Which of the following is primary prevention for polio? So primary prevention can be like nutrition, supplementation, vaccination, bed nets, defluoridation, condoms or chemoprophylaxis, personal protection. We have discussed a mnemonic in your classes, specific protection under primary level, NVBDCP, nutritional supplementation, vaccination, bed nets, defluoridation, condoms or chemoprophylaxis, personal protection. Answer is vaccine in early infancy. Physiotherapy, rehabilitation, all this will go in tertiary level. Collection of stool sample for diagnosis will go in secondary level. Secondary level. Which of the following is primordial prevention, that is preventing the risk factor? Answer is preservation of traditional diet in a low NCD area. Means you are reducing, you are preventing the onset of risk factor. Salt restriction, smoking cessation, all this will come under primary level, where your risk factor modification. Early diagnosis, it is under secondary level. Primordial level is preventing the onset of risk factors, preserving the diet in a traditional way. Africa, jaundice, Torres bodies, all these are going in favor of yellow fever. All these keywords will go in favor of yellow fever. 17D vaccine is the live attenuated vaccine for preventing yellow fever. Preventing yellow fever. Yeast infection, recurrent respiratory illness suggest the child is immunosuppressed. Live vaccine should not be given. Answer is MMR. Indirectly I am asking, see the question, considering immune status, that is also mentioned. That means they want answer as live. All the other are not live vaccine. Odd man out you have to do. Indirectly I can say which of the following is a live vaccine, or all of the following are not live vaccine except, means which of the following is live vaccine. This is the question which has been framed to say which of the following is a live vaccine. Out of that, MMR is the answer. Fifth class student means 10 years as per our country. 10 years we are using TD1. 16 years we are using TD2. TD1, TD2. Two doses of TD, not TT. TT is not a part of national schedule. Now, adolescent age, first dose, second dose. 10 years, 16 years. Answer is fifth class student, 10-year TD first dose. Encephalitis is the keyword. So the question is how Japanese encephalitis vaccine is given in the national schedule. 0.5 ml subcutaneous. See this word. 0.5 ml subcutaneous. It is ACA14-14-2 live attenuated vaccine, which is given in the left fold. Live attenuated vaccine and subcutaneous. Where is the site? Right or left? Left fold, because right fold we are giving MR vaccine at 9th month. Here we are supposed to give Japanese encephalitis vaccine in endemic areas. Health worker has received 2 open pentavalent vaccine, 1 open MR vaccine. What are you supposed to do? The question is on open vial policy. Good. Open vial policy is not applicable for BCG. It is given here. It is not applicable for BCG, measles or MR, JE, Rotavac and COVID related vaccine. These should not be used in the next session. Remaining all the other vials can be used in the next session. For how many weeks? For 28 days. If date and time is mentioned, that means you have to discard MR since it is not applicable. Use Penta since it is applicable. सुनो listen, not applicable याद रखना है आपको बस. Remaining all the other vials it is applicable, and applicable only if date and time is mentioned. That is why we have to mention date and time. Very important. Typhoid carriers was counted in 3 villages. See the words: village 1, village 2, village 3. You are counting the burden and you are telling which village is having more burden. You are not studying any association, just you are doing a cross sectional study in all the villages. You are telling village A, B, C. For example, village is A is having more burden, B is having more burden compared to C. Like that, you are comparing the burden. You are not studying any etiology. You are not doing any intervention. Trial is not the answer. You are not doing any intervention. Cohort, there is no follow-up, there is no case control, and there is no association. The answer will be cross-sectional study. Some students will make mistake in this. Not true regarding comparison of case control and cohort. Case control requires more time. No, this is requiring less time. You got the answer. Case control is less time consuming study. Case control will be less costlier. Cohort will take more time. Cohort will be more costlier. Cohorts are based on exposure pattern, correct? Cohort is generally prospective, mainly prospective, that is also correct. Case control should be used for rare diseases, that is also correct. Rare disease, don't do follow-up. Rare disease, we have to do case control study. Keep this in mind. Don't do cohort study for rare diseases. Which of the following is used to study rare genetic disease and an exposure to carcinogen? So the answer was there in the previous question. Answer is case control study. What should not be done for rare disease? Follow-up should not be done for rare diseases. So next question on cohort study. In a prospective study, there are two groups, 6,000 exposed and 4,000 not exposed. Out of exposed, 3 will develop disease. Out of non-exposed, 2 will develop disease. So when you make a table, 6,000 exposed, 4,000 non-exposed. Within exposed it is 3, within non-exposed 2. Risk is same. When you calculate risk ratio, it will become 1 because incidence in exposed and non-exposed, when you divide you will get it as 1. 1 means no association, protective factor. If it is more than 1, positive association, less than 1, negative association. It is neither protective nor risk factor. That means it is not having any association. Option B is the correct answer. Not having any association, neither protective nor risk factor. You have to calculate risk ratio for this question. False about RCT. Next question. Results of attrition can be included in the analysis. Correct. You can include by doing intention to treat analysis. Intention to treat analysis can be done. Randomization is done while selection of study subjects? No, it is after selection. Out of the total population, when you are selecting the sample, the initial step what is called as random sampling, not randomization. After sampling what you are doing, you allocate one into treatment group, the other into placebo group. That is called as random allocation, also known as randomization. Repeat with me, good. Random sampling is the first step, random allocation is the next step. Don't make mistake in the exam. Randomization is after selection, random sampling is during selection. Randomization is also known as random allocation. Double blinding is the most common type of blinding, correct. Crossover RCT will eliminate ethical problems, correct, because the group which was receiving intervention will receive placebo. The group which has received placebo will receive intervention. Means everyone will get that new drug either in phase 1 or phase 2. That will balance out the difference. It will reduce ethical problems. Association of tea drinking on blood pressure. They are doing an interventional study. Which of the following will increase external validity of the study? Listen now. Again, I am using the same word, population. Within that, we are selecting the sample. Like the first step, what I am doing is random sampling. After random selection, I am doing random allocation, dividing them into two groups and giving intervention. After getting the study results, generalizing the results back to the reference population. Generalizing the results back to the reference population is called as external validity of the study. Generalizing the results within the study population is called as internal validity. Now tell what is going back and generalizing the results to the whole group population. External validity, also called as generalizability. But within the study subjects it is internal validity. Careful monitoring of blood pressure will increase internal validity, including controls, internal validity, randomization, internal validity. Second step is called as randomization. This we have discussed. Random selection, the initial thing what we did, that will increase external validity. See the steps what I am showing. Once you know the flow chart, once you know the steps, it becomes very easy to mark the answers. That is why in the classes we are using flow charts. Initial step, random sampling. The next step is random allocation. Whatever you are doing in the study environment, that will increase the internal validity, like using proper instruments, control group, random allocation. But the initial step, random selection, will increase the generalizability of the study finding, also called as external validity. Association of high altitude with goiter is what type of association? It is indirect association, also known as confounding factor. See this sequence: high altitude and goiter has no direct relationship. Whatever is happening is indirect through iodine deficiency, which is a confounding factor. If this is the exposure, if this is the outcome, iodine deficiency is the confounder, means it is associated with exposure. High altitude areas, iodine deficiency is seen. It is an independent risk factor for the outcome. So what are the two properties of confounder? One, associated with exposure. Two, independent risk factor for the outcome. Confound means it come in between and causes the outcome. Like in the whole blame is going on altitude. No, it is not the correct. The direct association is not seen. Whatever is going, it is through indirect route. Confounder, it comes in between and causes the outcome. What are the two properties of confounder? The question was indirect association. The systematic error means bias, which happens in retrospective study, means case control study, which can be eliminated by doing a prospective cohort study. Answer is recall bias. Cases will recall their exposure better because they are diseased individual compared to control. Recall bias is seen in case control study. By doing a follow-up study starting from exposure going towards outcome, you are not asking any history. That is why cohort study recall bias is absent. Case control study recall bias is present. That was the question. The next question: all of the following are true regarding confounding factor except. It leads to indirect association. Yes, what we have seen, both exposure and disease, it has some association. Yes, correct. It is removed by matching in a case control study. Yes, controls will be selected similar to cases with respect to those confounding factors, and it is distributed equally in both study and control groups. No, there is unequal distribution. That is why it will distort the association, it will alter the association. There is unequal distribution of that factor between the study group and the control group. There is no equal proportion, there is unequal proportion. In matching, you can do group matching where you can make it equal proportion of confounders can be done by doing matching, but initially there is unequal distribution of confounding factors. True about varicella except 10 to 30% chances of reactivation, correct, leading to herpes. All stages of rash are seen at the same time. No, there is pleomorphism, different stages of rash at the one point of time. There is pleomorphism. Secondary attack rate 90, correct. Rash involves flexor aspect, correct. The opposite will be smallpox rash. Baby was given a dose of measles vaccine at 6 months of age. When the child comes at 9th month, you have to give vaccine. That is the answer. What should be the gap between two doses of measles vaccine? 4 weeks. In case of outbreak, you can give vaccine at 6 months. Starting from 6 months, you can give vaccine, but don't stop the routine schedule. Keep a gap of 4 weeks, continue the routine schedule and give the vaccine at 9th month. Which of the following is not true about influenza virus? Influenza E is subject to frequent antigenic variations, correct. There will be both shift and drift. both shift and drift. Gradual change is drift, correct? Antigenic drift is due to genetic recombination, no. Drift is due to point mutation. Genetic recombination leads to shift. Complete change in the serotype. Shift is seen only in influenza A virus. Drift can be seen in both influenza A and B virus, which is slow change, drifting, which is sudden change, shifting. Shifting is due to genetic recombination. Major pandemics are due to antigenic shift, correct? A new serotype, everyone is susceptible. Intercontinental spread, that can lead to pandemic. So the next question is on polio. Which of the following is true statement? While polio virus 1 is eradicated, no. We have eradicated 2 and 3, not 1. C. VDPVs are the rarest among VDPVs, no. They are the most common VDPVs, C. VDPVs. Circulating VDPVs are most common. OPV switch, what we have done to prevent VDPVs is from bivalent to monovalent. No, it is from trivalent OPV to bivalent OPV. Trivalent OPV was 1, 2, 3. Bivalent is 1, 3. The reason type 2 component is mutating more and causing C VDPVs. To prevent VDPVs, we have done switch in oral polio vaccine. Use of Chandler index. You know this, it is an average number of eggs per gram of stool. An average number of eggs per gram of stool for hookworm. It is mainly for hookworm. Since the word average comes, it is for the whole group, not for individual. We take it for the whole group, not related to individual. The uses of Chandler index, endemicity you can check, assess mass treatment of the community and which population is having more load, not for individual treatment and not for prognosis for a patient. It is not applicable at individual level. Remember, C for Chandler, C for community, it is for group. The most sensitive index for recent transmission of malaria in the community. I want to check the recent transmission. You have to assess the rate of infection among infants. Infant parasite rate is the recent indicator, like the indicator for recent transmission of malaria, not adult parasite rate. Spleen rate will indicate endemicity. Annual parasite rate or incidence will indicate new cases. Slide positivity rate, total slides examined, how many slides are positive? The answer is infant parasite rate. Which of the following species of Anopheles is highly anthropophilic? Means even in low density it can infect human beings like anything. The answer is Anopheles fluviatilis. Very important. It is the highly anthropophilic species. A 10-year-old with unprovoked dog bite comes to you. What is the next action? Withhold the vaccine and observe for 10 days? No. We have to start the vaccine as soon as possible. If the dog is normal after 10 days, you can stop. But don't observe the dog and then start vaccine. We have to start vaccine as soon as possible. Observation is done, it is not mandatory. If the dog is normal after 10 days, you can stop the schedule, but the question is start vaccine as soon as possible. That is the answer. For treatment of class 3 dog bite, which of the following is not done? Immunoglobulins given, yes, very important. Vaccine is given. Category 3, both vaccine and immunoglobulin. Immediately stitch the wound? No, we have to delay the wound suturing, not immediately. Washing is done? Yes, wash, vaccine, immunoglobulin, delayed suturing if needed. We have to give TT vaccine at the same time antibiotic prophylaxis in case of category 3 bite. Fever, chills after exposure to louse. These are the keywords. The answer is epidemic type, which is not used for preventing Casanova forest disease. As you can see, the vector is heart-tick, which is responsible for KFDs in India. Vaccination is effective in endemic areas. Skilled vaccine is advised. Deforestation should not be done. Preventing roaming of cattle in the forest important because cattle is going into the forest, that is feeding the ticks, increasing the tick population, and personal protection. In order to prevent tick bite, we have to use tick repellents. Deforestation is not advised. Which of the following is wrongly matched? Related to disease and vectors, Epidemic typhus, louse, correct. Scrub typhus, flea, no, it is mite. Trombiculid mite is the vector for scrub typhus. Rocky Mountain spotted fever, tick, correct. Rickettsial pox, mite, correct. Highlight this question, important. They're asking questions on rickettsial diseases and vectors. I made the question easy. Scrub typhus, very important. The vector is not flea, it is trombiculid mite. Neonatal tetanus is said to be eliminated. What is the elimination target for neonatal tetanus? Answer is less than 1 per 1000 live births. So what they are doing, they are defining it as less than 1 per 1000 live births, and this target has to be achieved in every district. So it is the elimination target to be achieved at every district. Safe strategy, very easy question. Screening is not a part of safe strategy. What is safe? Surgery, antibiotic, facial cleaning, and environmental improvement. What is the antibiotic used? A for antibiotic, A for azithromycin is the antibiotic of choice. Surgery, antibiotic, facial hygiene, and environmental sanitation for preventing trachoma. For controlling urban rabies, which is the most cost-effective strategy as of now? Answer is eliminate stray dogs and mass vaccination of dogs. This is the most important cost-effective strategy for rabies elimination. Very recent question. Which of the following is the vector of CCHF, Crimean Congo hemorrhagic fever? We have discussed in the classes mnemonics CCHF, C for cattle, C for camel, reservoir, C for cattle, C for camel, reservoir. H is the vector, heart tick is the vector causing Crimean Congo hemorrhagic fever. So many things have been discussed in your classes. All these are PYQs related to your class notes only. How to manage HIV TB co-infection? If both are diagnosed together, start TB treatment first. Start TB treatment first, then add ART to that. Then add ART. If ART to be added, keep a gap of 2 weeks. So start ATT followed by ART if it is co-infection. Patient was on TB treatment, smear negative both after intensive and continuation phase, both negative. Then the patient is labeled as cure. If intensive phase negative and the results are not available after continuation phase, if the results are not available, we call the patient as treatment completed. But your question is both negative. See the table. If both are negative, if both are negative, then we call it as cure. Then we call it as cure. Or first time negative, second time the results are not available, then we call it as treatment completed. C for cure, C for treatment completed. Outcome of TB treatment. Institutional delivery, urban area, low performing state. Urban area, low performing state. The table is given for you. Answer is option C. See this, the table under Janani Suraksha Yojana, rural area, urban area. This is how you classify. Low performing state, high performing state, depending on the rate of institutional delivery. Always keep this in mind. Rural area ASHA will get 600, urban area ASHA will get 400. ASHA worker is simple to remember. Rural area we give more incentives. We want to promote hospital delivery in rural areas. The only thing you have to remember is mother. Rural area 1400 and 700, urban area 1000 and 600. Your question was urban area low performing state. Urban area low performing state. ASHA worker, remember this, important. And again, there is a scheme, Pradhan Mantri Surakshit Matritva Abhiyan. Stickers are used. PIH, pregnancy induced hypertension. What sticker is used? Blue sticker. High blood pressure, B for blood pressure, B for blue sticker. Green indicates no risk factor, red high risk pregnancy. Blue is important for me, pregnancy induced hypertension. Yellow color, yes, we have comorbidities like diabetes, hypothyroidism and STIs. For them separately we are using yellow sticker. So repeat the stickers used: green, red, blue, yellow. What was your question? Blue. Very good. Indian Newborn Action Plan target again single digit neonatal mortality rate by the year 2030. We have to achieve this target at the national level. Single digit neonatal mortality rate, at the same time single digit stillbirth rate. This target has to be achieved by which year? If they ask, it is by 2030. It is by 2030 at national level. Single digit both neonatal mortality rate, at the same time still birth rate. Pregnant northeast area malaria treatment I am asking, but what malaria treatment? It is falciparum malaria. This was the question. Second trimester we can use ACT. First trimester we are using quinine. Second trimester we can use ACT. ACT used in northeast states, artemether, lumefantrine combination. ACT used in other states, artesunate SP, but ACT used in northeast states, artemether, lumefantrine. Remember, pregnancy first trimester quinine, second and third trimester ACT. Northeast area is important. Artemether, lumefantrine is the combination. Pregnancy, Primaquine is contraindicated. Treatment of choice for a patient with RK39 positive report. What is RK39? Rapid diagnostic kit for Kala-Azar. Very good. The drug of choice is liposomal amphotericin B. This is the drug of choice, not sodium stibogluconate. It is LAM what we are using now. False regarding AFP surveillance. Polio surveillance, stool sample collection and transportation, which is wrong. Option D is wrong. Non-polio AFP rate is an indicator for operational efficiency. Yes means how many cases of AFP they are detecting. AFP can be polio, etc., like VAP, Guillain-Barré, transverse myelitis, traumatic neuritis. It can be anything out of this. We have to identify at least 2 cases per 1 lakh population. Now the indicator is 2 per 1 lakh. Sample should reach the lab within 72 hours. Quality checking is important. Temperature 2 to 8, reverse cold chain. Adequate sample collection from 80% of the cases, minimum 80, not 100. What is adequate sample? 8 gram per sample collected within 2 weeks. 8 gram per sample collected within 2 weeks. Which of the following is true for newly diagnosed HIV patient? Start treatment if CD4 is less than 500. No, we have to start treatment irrespective of CD4 and clinical staging. That is second statement. That is also correct. And the third statement is screening for TB in all HIV patients. That is also correct. We are using CBNAT for diagnosing tuberculosis in HIV patients. So 2 and 3 is correct, 1 is wrong. We have to start treatment irrespective of clinical staging, So kits which are important, Suraksha clinics, STI kits, we have discussed the kits. Option A is correct. So there are 7 kits which are there: gray, green, white, blue. So it's like go green with blue rivers and yellow birds. This was the mnemonic which I gave in the Instagram for you. Go green means gray green, with blue, white blue, river red, yellow and black. 7 kids. Good. So discharge gray, vaginal discharge green, important. White, ulcer non-herpetic. If it is allergic to penicillin, we are using blue. Then red, important, herpetic ulcers. Lab, abdominal pain, yellow, and black inguinal bureaus. Go green, gray green, white blue, red, very good, yellow and black. How many kids? 7 kids under go green with blue rivers and yellow birds. So question number 60 is on sensitivity specificity. Out of 200, 180 are detected, sensitivity 90%. Out of 200 normal, 150 are detected, specificity 75%. So make a table. Out of deceased, how many are detected? This was the question. Out of 200, 180 are detected, 180 true positives, 90% sensitivity. Out of 200, 150 are detected as normal. So true negatives 150, specificity 75%. We have to make a table. You have to fill the corners 180, 150. Always I am telling, corners are very important. Within the corners your questions will be there. So it is 180 and it is 150. 180, 150 related question you have to know. 90% sensitivity, 75% specificity. Test is giving the same values. That means it is precise. It is precise, but not measuring the actual value, not accurate. Giving the same values is precision, measuring the actual value is accuracy. So your question is saying it is precise but not accurate, not valid, not valid. The probability of having disease after a positive test, that means it is positive predictive value. The test results are positive. What is the chance of having disease? Everything within the words. Positive prediction, having disease expressed in percentage. Test results are negative. What is ruling out? Negative predictive value. What is ruling in? Positive predictive value is the answer. The test was done. If the first test is positive, then we do the next test. Then we assess for further evaluation. That means it is sequential testing. So go back to the class notes. We have revised your sequential testing part. Answer is specificity will be better, PP will be better. It is more confirmatory. If the results are positive on the last test, chance of having disease is more. It is more confirmatory. So if these two things are increasing, the other two things will decrease. So the question is on sequential testing. If you remember one side, either you remember sequential testing or simultaneous testing, because both are completely opposite, like smallpox and chickenpox. You can remember anything. In the exam, if they say tests are done together, that means it is simultaneous testing, parallel testing. Tests are done one after the other. That means it is sequential testing. Your question was on sequential testing. Good. Which of the following is true for a screening test? Specificity is 1 minus false negative. No, it is 1 minus false positive. You should know the table, 2 by 2 table. This is true positive and false negative. True negatives and false positive. Sensitivity is this in true positive corner, and specificity is in this corner. This is sensitivity, this is specificity. So specificity is 1 minus false positive, sensitivity is 1 minus false negative. So this is also wrong. This 1 minus false negative, both are going opposite. If it is 80, the other is 20. Predictive value does not depend on prevalence. No, it depends on prevalence. Positive predictive value is always directly proportional to prevalence. Negative predictive value is inversely proportional to prevalence. Keep these two equations in mind. PPV is directly proportional to prevalence. Higher prevalence, high risk population, if the test results are positive, more chance of having disease and less chance of rolling out. That is why HIV testing in a prostitute, if it is positive, chance of having disease is more. So all the statements are false. This question is very, very important. So question number 64. PPV and prevalence based question I am framing. So listen now. Prevalence of disease has come down by 60% by a new vaccination program. What will be the impact? Sensitivity, specificity will not change with respect to prevalence. PPV will decrease because prevalence has come down, and NPV will increase. PPV will decrease and NPV will increase because prevalence has decreased in the question because of a new vaccination program. Answer is option B. The ratio of true positives and false positives of a test is positive likelihood ratio. The percentage of true positive result, sensitivity, divided by the percentage of false positive result. The formula for positive likelihood ratio is sensitivity over 1 minus specificity. Keep this in mind. So question number 67 says, if I am telling the natural history of disease like cancer, point A is saying disease onset. Point A is saying disease onset. Point B is first possible point of detection where the patient is asymptomatic. Point C is critical point because after this you cannot change the natural history. Point D is usual time of diagnosis where the patient will come with symptoms, fever, weight loss. E is the outcome. E is the outcome. So the question was where we have to do screening. Screening has to be done between B and C because C is the final critical point. After C, if you are doing, you cannot change the natural history. Screening has to be done between B and C. But what is the gap between the first possible point of detection and diagnosis? That is a different question. Detection and diagnosis, the gap is lead time, profit time. But this gap what I am highlighting, your question was not on lead time. Your question was on screening time. This is screening time. This is lead time. So both are different. After C, you cannot change the natural history. So screening has to be done between B and C. So the next question is, which of the following is an example of prospective screening? Means a communicable disease where you can prevent the spread of disease. Answer is screening of immigrants at airport. What is prescriptive and prospective? What is prescriptive and prospective screening? See here, prospective screening is for communicable diseases where you can prevent the spread of disease. Disease control is my purpose, where you can prevent the transmission of disease. Disease control is my purpose, like HIV, swine flu in immigrants. But here, prescriptive screening is for non-communicable diseases where you are preventing the progression. Patient will have more benefit. Here, the benefit is for the patient, like diabetes, hypertension, cancer, non-communicable diseases. Here the other side is HIV, swine flu, COVID. See the example: pap smear, cancer; breast self-examination, cancer; neonatal screening, all those genetic and metabolic deficiencies what you are screening for. All this will help the patient. Non-communicable disease, keep it simple. Non-communicable disease progression we have to prevent, then the advantage is for the patient. Prescriptive screening, when there is community transmission one to one, we have to stop that. Disease control, that is for communicable disease, that is prospectus, means we think ahead. Prescription means at that point of time what is the advantage for the patient. Non-communicable disease prescriptive, communicable disease prospective. Which of the following criteria, or which of the following is not a criteria to apply a screening program? Option B is wrong. Natural history of the disease is not adequately understood. No, it has to be understood, then only screening is more beneficial. Who gave this criteria? See here, it is Wilson and Jungner's criteria for screening. The disease should be an important public health problem. The natural history should be understood properly, then only will be coming to know like where I have to put intervention, when the patient will get advantage, whether I am doing screening at stage 2 or stage 3. That idea should be there, that is course of the disease has to be properly understood. There has to be a latent phase, then only there is advantage if you are doing screening. Test is available, test is acceptable, and agreed policy on whom to treat, whether we have to treat that patient if he is positive or not, that policy has to be written. And treatment should be available, diagnostic facilities should be available for confirmation, and it should be cost effective. Always keep this in mind, screening should be cost effective at public health level, and it should be a continuous project. Like you are doing now, and if you are stopping, that won't create confidence in the system. It has to be a continuous process. So if you are starting for cervical cancer, you have to be continuous, not that 1 year you do, next year you are stopping. That will not be an advantage, and you won't gain that confidence from the system. Patients or community will not respond if you are going the next time for screening programs. Good. So vector-borne disease is showing increased trend in monsoon season or post monsoon season. You are plotting the trend of a disease. What is the image which is preferred? Answer is line diagram. Is the very important diagram in order to plot the trend of a disease. If you want to show trend, x-axis, line diagram. If the cases of dengue which was reported 1 month, it was like in 1 year it was around 6,000. Compared to the other years, 6,000 is complete outlier. We call it as extreme value, outlier present. If the data is having outlier, it is called as skewed data. If the data is skewed, mean is not used. Median will be the preferred measure. Keep this in mind. Median is the preferred measure for skewed data. So many times they repeated this question. The BP of 200 persons was collected. The first quartile and the third quartile values are given. So what is box whisker plot? This is the minimum value. This is the minimum value, and this is the maximum value. What is the central value? Median is called as Q2. Q2 means second quartile. Median, this is Q1 and this is Q3. Q1 and Q3. The distance between Q1 and Q3, this was the question. If there are 4 parts, every part will have 25% of the data. See here, every part is having 25% of the data. The distance between two quartiles is called as interquartile range. Q1 and Q3 का जो gap है ना, that is interquartile range covering 50% of the data. Very good. 200%, 50%. Answer is 100. Answer is 100. Good. Come to the next question. All the babies born in the hospital 2.6 kg. That means there is no deviation. What is standard deviation? 0. When you take the mean and the individual value, when you put the formula also, standard deviation is 0 because all are having the same weight. This is just a theoretical question. You can't imagine 15 babies in a hospital with same weight of 2.6 kg. Then the whole media will come and ask what happened, but still your answer was there is no deviation, dispersion is 0. Yes, good. Subgroups. See the question, see the keywords, subgroups, age wise. Fine. The researcher wants to select randomly later from each subgroups the individuals based on their size. So everything is clear cut. You are making different subgroups, strata, then based on their size you are selecting randomly. Stratified random sampling, individuals are selected, individuals will be the final sampling unit. When you make strata, always keep this in mind, there are certain characteristics you have to consider like age or sex, or it can be religion, but in your question I'm giving age wise. This is also stratified random sampling, important. A study was done with 100 patients initially and you got a confidence interval of this much. But what the question was, if you are increasing the sample size, what will happen? Always keep this in mind. If the sample size is increased, standard error will decrease. Standard error formula, like for mean, if I am telling, it is standard deviation by root sample size. If I am increasing the sample size in the denominator, standard error will decrease. Standard error is decreasing. Using standard error, you calculate width of the confidence interval. You are calculating width of the confidence interval. So width of the confidence interval will decrease. Width of the confidence interval will decrease. Always keep this in mind. If sample size is increased, standard error decrease, width of the confidence interval will decrease. Very important question. What are the tests used? If I am telling mean two groups, between two groups, student t-test, also called as unpaired t-test. Mean one group before after intervention, we are using paired t-test. One group before after intervention, we are using paired t-test. Mean three groups, we are using ANOVA test. Student t-test is also called as unpaired t-test, paired t-test, and ANOVA test. What is the mnemonic? SPA. Parametric test. These three are parametric tests used to compare mean between two groups, mean one group before after paired t-test, and mean more than two groups ANOVA test. In the answer section, I am giving the other tests used, parametric and non-parametric. You can take it later. I have given the PDF in our Instagram page also. Not true about chi-square test. Chi-square test can be used to compare difference between proportions, two or more than proportion, correct, two or more than two. Test of association, correct, between exposure and outcome. If I want to check the significance of association, very important, chi-square can be used. Directly measure the strength of association now. Strength is given by odds ratio or risk ratio. Chi-square can indicate significance of association, not strength of association. Can be used when more than two groups are compared. That is correct. Proportions, two or more than two groups, chi-square test. Association, most commonly used, chi-square test. Rejecting a true null hypothesis means there is no difference between A and B. Both are equal. Treatment and placebo is equal. That means there is no difference, but you are telling that there is a difference. Rejecting a true null hypothesis. Null says no difference, but you are saying that there is a difference and selling your drug. You are committing false positive error in the study, also called as type 1 error. Got my point? Type 1 error. All are true about p-value except p-value will indicate how much is the false positive error committed in the study. That is also correct. That means You are saying that the difference is present when actually there is no difference. That is type 1 error. The amount of type 1 error committed is p value is less than alpha. The results are statistically significant. Means alpha most of the time we keep at 5%. That is the upper limit. P should be less than alpha. Always P should be less than alpha. That means less than 0.05, less than 5%. Then you can say that the results are statistically significant. How to say the results are statistically significant? The limit is alpha, most commonly used 5%. If the P is less than alpha given by the statistical test, your results are statistically significant. Is it equal to 1 minus beta? No, 1 minus beta is power of a study. That is completely opposite of type 2 error, false negative error. See this question. A study was designed to check the association between arsenic and risk of cancer. Small studies previously done has identified the association. They are telling it is present. Your study should also identify the association and should not commit type 2 error. Means beta should not be committed. You have to reduce beta in your study. That means you have to increase power of your study. Power is 1 minus beta. How to increase power? Take a big sample size, not small set of patients. Power is directly proportional to sample size. Very important. Listen, beta is false negative type 2 error. You have to reduce beta. To reduce beta, yes, you have to increase the power. To increase the power, you have to increase the sample size. I am writing the equation. Increasing the sample size will reduce beta in the study. That means if you are reducing beta, since power is equal to 1 minus beta, if beta is reduced, power is increased. So finally I am telling power is directly proportional to sample size. All these are just a rapid revision of all the points which has been discussed in your classes and posted on Instagram. Good. See this question. A female with a baby of 3 months means lactating coming to the clinic. Her previous energy requirement was 1900 before pregnancy. So the lactation part in the initial 6 months it is plus 600. After 6 months it is 520. So what you are doing, you are adding 1900 plus 600. Answer is 2500 kilocalories. What is the energy requirement now in the initial 6 months? Patient is having rough and dry skin, and very important is papular eruptions on the posterior and lateral aspect of limbs on the back. Underline this, papular eruptions. So what they are commenting? They are commenting on toad skin. They are commenting on toad skin. Phrynoderma. Phrynoderma can be due to both essential fatty acid deficiency and vitamin A deficiency. In the option given, it is essential fatty acid deficiency. Patient with maize eating history, and they're complaining of diarrhea, dermatitis, and dementia. Very easy question. It is pellagra, and pellagra is due to niacin deficiency. The reason why there is pellagra in maize is due to lack of tryptophan. There is no tryptophan, so there is no niacin synthesis. That can lead to pellagra. Patient had an history of consumption of kesar dal for a long time. Madhya Pradesh and kesar dal, that means you have to think of neurolathyrism, which is not a method of prevention. Nalgonda is used for preventing fluorine excess. So it is defluoridation technique, but not for neurolathyrism. Steeping method, parboiling of pulses can remove the toxin BOA. It is helping in removing the toxin BOA from kesar dal. Vitamin C prophylaxis can also act as a preventive method for neurolathyrism. Mother, again lactating mother coming to OPD with calcium assessment when you are doing of her diet is 800 mg per day. What is missing? 400 mg, because calcium requirement in lactation is 1200. Calcium requirement in lactation is 1200 mg per day. In pregnancy it is 1000 mg per day, but in lactation it is 1200 mg per day. So she is missing around 400 mg because her energy or that calcium in her diet was 800 mg. Which is the only fertility indicator which includes mortality also? Means both fertility and mortality. Answer is net reproduction rate. That means On an average, one newborn will have how many girls in the future? One newborn female or newborn girl will be having how many girls in the future? That means you have to consider the mortality pattern also, because you are starting from newborn. And for net reproduction rate, and for newborn will have in the future, number of girls a newborn girl will have in the future, indicating replacement level also. Pearl index is for failure rate of a contraceptive, also said as efficacy of a contraceptive. How good is the contraceptive? How good means if the Pearl index is lesser, the failure rate is less, the efficacy is better. How it is expressed? Per 100 women years. Lesser the failure rate of a contraceptive, more efficacy for that contraceptive. Good. Medical officer at PHC, a woman, she is coming and asking for an injectable contraceptive. So as per the newer program Mission Parivar Vikas, injectable contraceptive used is Antara. So what is Antara injections used? Antara is DMPA, depot medroxyprogesterone acetate. Chaya is non-hormonal OCPs. It is ormeloxifene. Before it was under the name of Saheli, now it is under the name of Chaya. Antara is an injectable contraceptive. Today is vaginal sponge. Today is vaginal sponge. In a population, there were 4050 births in the last year. 50 were stillbirth. That means live birth 4000. You have to subtract stillbirth and take only live birth. 50 died within 7 days and 150 died within the next 28 days. Means total 50 plus 150 in the numerator. 50 plus 150 in the numerator, because it is neonatal mortality what they are giving. So numerator is 200, denominator is 4000. So multiply with 1000 and calculate neonatal mortality rate. This was the question. So neonatal mortality rate is deaths within 28 days. A pregnant in her second trimester is coming for antenatal checkup with a 2-year-old child. That means she is having a 2-year-old child. So what is the TD schedule what we are giving now? TT is not followed. What is the TD schedule what we are supposed to give? Give 1 dose of booster. Any pregnant, she has been vaccinated previously, happens again if she conceives within 3 years. Within 3 years, we are supposed to give booster. After 3 years, if she is conceiving, she has to take 2 doses. If I am telling coming with a 6-year-old child, then your answer is 2 doses of TD. Now my question is 2-year-old child within 3 years. Answer is TD booster. Very good. Next question. Series of speeches among experts without any discussion. This is clear cut. Symposium. What is symposium? Series of speeches without any discussion. S for symposium, S for series of speeches. What is panel discussion? There is discussion among experts. There is no proper order of speeches. That is panel discussion. They sit in a panel and they will discuss. But in symposium, S for symposium, S for series of speeches without any discussion, one by one, that is symposium. Not true for chlorination of water. So contact period of 6 hours is wrong answer. 1 hour or 60 minutes will be sufficient. Normal condition FRC 0.5 is sufficient. Water should be free from turbidity, important, and chlorine demand we estimate, then we add bleaching powder. We use ROX apparatus, then we estimate chlorine demand, add bleaching powder. Contact period is 1 hour. Kata thermometer is used to measure. So listen to my words properly. Initially it was used for cooling power of the air. Now it is used to measure low air velocity. Initially for cooling power, now for low air velocity. You are taking a team from your vector-borne disease control department and you are going and identifying water lodging places and clearing it. What is this type of vector control? What you are doing is environmental control, called as source reduction in malaria. Source reduction means reducing the breeding spots. So this will come under environmental control. Environmental control. What you are doing, you are investing 2% extra amount on the procurement of drugs. Cost is the input, and the output what you are checking is the incidence of cardiovascular accidents which you can prevent. That means output is results. Input is money what you are putting, output is the amount of deaths what you can prevent. It is cost effective analysis. What is cost benefit analysis? Money, money. Input also money, output also money. That is cost benefit. Here it is cost effectiveness. Input is money, output is result. Very, very good question. See this question. What is happening in a primary health center? 10% of the drugs will account for 70% of the cost. Those are classified as A drugs. Very important drugs. A drugs. 20% of the drugs account for 20% of the cost. Those are B drugs. 70% of the remaining drugs which are cheaper comparatively account for 10% of the cost. They are classified as C class of drugs. 70, 20, 10. This is how they account for the cost. Class A drugs are very, very important. They are very, very costly. This type of analysis, what you are doing based on cost factor, is called as ABC analysis. Very important. Stock management. What is ABC analysis? What is A, what is B, what is C, which class of drugs are very important. Like that, if they ask, it is ABC analysis based on cost. A class of drugs is very, very important. Needle injury we have to avoid by disposing the needles in what container? This is the question. Answer is sharps will go in white container. Anything which can cause cuts or puncture wounds like scalpel or sharps like needle, they have to go in white puncture proof container. Post disaster, what should be the level of residual chlorine? Normal condition we keep 0.5. After a disaster we have to increase it by extra 0.2 to 0.5. This is what is given in the textbook. Extra addition you have to do. Normal condition is 0.5. For that you have to add extra 0.2 to 0.5. Means anything in the range of 0.7 to 1 is sufficient. This was the recommendation. So you are adding 0.2 to 0.5. So anything in the range of 0.7 to 1, that means more than 0.7. This will be the question. In order to reduce gastrointestinal infection, because gastroenteritis is the most common outbreaks which can happen after a disaster. That is the question indirectly. See here, you are going to a flood affected village and your purpose is to prevent diseases. Whether we advise vaccination against cholera, typhoid or tetanus? No. There is no mass vaccination for cholera, typhoid and tetanus. There is no mass vaccination for cholera, typhoid and tetanus. What you are advising? You are advising proper safe water and sanitary condition in order to prevent GI gastroenteritis. Very, very important. Gastrointestinal infections. What is the best method to prevent any GI infections during any disaster? If they ask, is it vaccination? No, it is proper safe water and sanitary condition. Come to the last question. We have finished 100 question discussion within 1 hour almost. It was a rapid review of all the questions which has been posted on my Instagram page, which you are following since 2 to 3 months. And coming to the last PYQ, 100 PYQ is on health committees. You are a medical officer at primary health center. If you are referring the patients to the higher center, you can save the life of the patient. There is proper referral service complex which has been established, like PHC you refer to CHC, from there we refer to district hospital. This was the contribution of Srivastava committee. Very important. Referral service complex has been proposed by Srivastava committee. Good. So all these are PYQs, 100 PYQs posted in my Instagram channel. So my Instagram link you are following since 2 to 3 months, Rajiv Shetty, and I've been posting all the important PYQs and updates in my page. And this was the 100 PYQs posted. And you are asking me, sir, can we get a video which I can revise this at one point of time in a rapid, concise way? So for that purpose, I made this video in a rapid, concise manner, covering all the important keywords of 100 PYQs. Hope it has helped you for the revision, rapid revision overall. And the idea what you're getting is, what are the important things we have to focus when a question comes, what are the important previous year topics on which the examiner is focusing the topics on. That was the main purpose of that, so that you get that confidence is very, very important. Once you have that confidence, that positivity will radiate and you will see that change in the exam. It's not that knowing everything, it's that knowing most important thing and having that confidence will give that extra edge for you to mark some extra questions and get that extra answer. And that is the only difference in a competitive exam. It's always going that extra mile for you. So finally I want to say this, it was like 3 months we are being together in the Instagram part and posting on those questions and this video to revise with. So like we always say, it was a journey, the suffer what you have enjoyed for these 3 months. Thanks for being a part of our journey. Like we have that song, right? Safar ka hi tha main, safar ka raha. Thank you so much. God bless. Best wishes. All the best.